Well, welcome everyone, and thank you for joining us from a range of different time zones. And to start off today's event, we thought that we might first briefly introduce who we, the hosts, are. So we are an organization called Black and Brown in Bioethics, and we launched this organization following the realization that there are no regular events in UK bioethics, which are led by people of color or focus on issues affecting ethnic minorities. And so our mission is to achieve racial equity within the UK bioethics community by creating a network that expands opportunities for community engagement, promotes anti-racism, and accelerates the well-being, education, and health of all people of color. And our team is composed of three of us. So first of all, we have Harleen Kaur-Johal, who is from the University of Bristol, and unfortunately, she wasn't able to join us today because she's feeling unwell. And then we have Matimba Swana here with us, who's also from the University of Bristol and is actually the mastermind behind today's event, the webinar. She organized and put everything together, so thank you for that. And then I myself am Kumari Bandara, and I am from the University of Oxford. And from there, I'll actually hand it over to Matimba to take it forward and introduce today's event, the theme, and the speakers.
Thanks, Kamau. Thanks everyone for joining. So today our theme is Insights from Industry, Inclusionary Digital Health. And one of the reasons we wanted to do this theme is just the sheer increase of digital health technologies that are being used within the healthcare technology industry, and that's both the public and private sector has increased hugely over the last couple of years and is forecast to increase tremendously in the next 10 to 20 years. And one of the focus areas is really around inclusion strategies and what does the digital health inequality landscape look like. So today we're actually going to talk about it from a couple of different angles. So not just talking about it from the patient side of things, but from what happens in the clinical trial industry to once this technology is available for market access, with a good example of use case from Canada and the Canadian kind of healthcare space, and also the public health space when this is being used by healthcare professionals. So we are very, very grateful for all of our panelists today, and we're particularly grateful for our host, who I'm very happy to introduce, is Arianna. I don't know if Arianna's able to get.
Hi, I may not be able to use my camera, but I hope you can hear me. I switched it on. Let's see if it works, but apologies for that.
Okay.
I'm having some troubles with my video. Yeah,
just fitting for a digital health webinar. Yeah. So Arianna, who you can't see but is definitely there and we can hear, is a research scientist at DeepMind. Arianna is an ethicist and is very passionate about working in interdisciplinary teams to address complex societal challenges around technological advances. Arianna also has extensive experience in engaging the general public in debates about technology and ethics, especially in health-related contexts. Before joining the ethics research team at DeepMind, Arianna was a research associate here with us at the University of Bristol, where she collaborated with computer scientists and roboticists on a project on trustworthy autonomous systems, looking at soft robotic systems, UAVs and swarm robotics. Arianna holds a PhD on ethical concerns around emerging technologies in autism genomics from the University of Oxford. And we're very pleased to have her here. So I'm just going to hand over to you, Arianna.
Thank you so much, Matimba, and thank you and Kumari for the invitation. So I'm going to introduce the experts who we will be hearing from today. So first we will hear from Niyoshi Shah, who is a consultant at Quicksand Design Studio. Niyoshi is a qualitative researcher and writer who has completed her master in critical writing from the Royal College of Art. in London in 2018. And she has a long-standing interest in the question of linguistic equity, where she's constantly looking for ways to improve health and care access for those who don't consider English as their dominant language. And her concerns regarding culturally sensitive communication were presented as a case study at the Global Forum on Bioethics in Research in 2021. Niyoshi currently works, as I mentioned, with Quicksand Design Studio on their project in the social sector with a specific focus on health and new technologies. Next, our second speaker is Evelyn, or Eve Kamau, who is Senior Director at Thermo Fisher Scientific. She has a long career as a nurse for over 20 years with both UK and international nursing experience. And in addition to critical care, neurology, clinical trials, and community nursing experience, he has a special focus on decentralized clinical trial, where she has helped support over 100 clinical trials in the home environment over the past 7 years. And she won STEM Senior Leader 2023 Black British Business Awards. And finally, our last panelist is Srushhti Trivedi, who is a consultant, educator, and ethicist at Amaris Consulting. She's working full-time in the evidence review team at Amaris Consulting, and she works in the life science consulting, where they support pharmaceutical clients in drug reimbursement submissions. She's also an ethics expert at the Ethical Intelligence and advises on developing AI ethics frameworks and policies and more for internal and external clients. And she has a master's degree in bioethics and a bachelor in medical biotechnology. And lastly, her research interests include exploring the role of ethics in pharmaceutical industry, the use of AI in healthcare, and global health ethics. So it's an amazing group of panelists. And just very quickly, I will explain what the program is. We will hear from our speakers for 20 minutes each. So we'll have 20 minutes with Niyoshi, whose presentation will focus on the role of design in public health. And she's going to focus in particular on a case study on artificial intelligence for behavior change in health. The second talk will be from Eve, again 20 minutes, focusing on using decentralized trial solutions to increase patient diversity. We'll then have a 10-minute break. And when we come back from break, Srushhti will be speaking about perspectives and processes involved in market access of digital health and related ethical issues. We will then have a 30-minute panel discussion. And finally, the host will close this session and we'll tell you about our upcoming events. Quick housekeeping before I hand over to Niyoshi. We will save the questions for the panel discussion, but please use the chat function or the Q&A throughout the presentations to ask questions for our panelists. And Matimba and Kumari will keep an eye on the chat and the Q&A functions, so that we are ready to cover all your questions during the panel discussion. We want this webinar to be interactive. We want you to ask lots of questions, but please be respectful of each other. Try and engage in a respectful way. And so I think this is all from me. Niyoshi, do you want to take over?
Thank you so much for that wonderful introduction, and thank you so much for the invitation as well, Matimba Kumari. I will get right into sharing my presentation. And thank you for the others for joining wherever you are in the world. So I will be presenting one case study from the work that we've done at our design studio. The project's name is Safe Hands, and it was a project where we were looking at the use of artificial intelligence for behavior change. So A little bit about my organization before I get in. So Quicksand is actually a design strategy and innovation consultancy in India, but we work across sectors. So we work in health, education, financial inclusion, and also the commercial sector, and across countries as well. So, it's quite a wide practice. And I've just put together a few pictures to give you a sense of what our work looks like. So the first one was on female contraception. We've also worked for health system resilience, which is the second one. We've developed games for HIV. We've looked at government job aspirants in India, and so on. So it's quite vast. And if there are any questions on our practice, I can take them later. So about the project that I'm going to be speaking, these are the topics I'll be covering. There's the background, there's a little bit about the design process and how it applied to this project, and what we learned by the end of it. So to start right away about the project, the problem is actually deceptively simple. So, in most healthcare settings, it is well understood that hand washing is one of the main ways in which you can prevent infection, or like prevent its spread. But despite that knowledge, the compliance to hand washing or hand hygiene actually is as low as 37%, the global average. And this is across high, middle, and low income countries. So usually this problem is solved with manual methods where you might have somebody training the staff or supervising them, or they might have some evaluation mechanisms, but you can imagine how that would be riddled with bias, or in resource intensive settings, you can't spare a staff member to take on these duties. So there is talk of using artificial intelligence for this kind of quality improvement or compliance, as it would be called. In our project, we had an added component of sort of implementing AI or exploring how AI might do this work from the lens of human-centered design. So the question, first of all, being why human-centered design? So it, in a lot of Indian public health facilities, they can be very hierarchical, and if new technologies are implemented without a social understanding of this, the environment in which the staff works, you might actually exhibit structural disadvantages. And these hierarchies are also, I mean, the factors for them can be multifold. I'll just elaborate a bit on that because we're talking about inclusion, exclusion. Sometimes it can be on the lines of qualification. So there can be differences in how you think about the medical staff versus the paramedical staff versus the non-medical staff who's primarily responsible for janitorial work. The hierarchy could also play across seniority. So, of course, the ones who are more senior probably have, the power dynamics leaning in their favor. There's also this component of work, which I will bring up again. Depending on the work you take up in the ward, typically cleaning work is considered dirty, where you're sort of dealing with biomedical waste. And that obviously also decides your status in the hierarchy. There's also work status in the recent past, as more and more government jobs are contractualized. So you can have permanent labor versus temporary labor who come in on a contract basis, and that can also play into this hierarchy which I'm speaking of. And there are other researchers who've also spoken of how our social reality shows up in these ward relationships. So in India, for example, caste is a very big question, and it can cut across all the other hierarchies I spoke of. I have a link to a good podcast on that if anybody's interested, but we can come back to it. So, given this kind of complexity, it makes a lot of sense to come to a problem from a human centered or a people centered lens. Briefly elaborate on what the human-centered design process is. It typically starts with research where we're trying to understand the user's needs, preferences, and constraints. Though quickly to these solutions have to be perfect. And those solutions are taken to the ground quite early on so that you can improve by continuously and get feedback. What that essentially means is that the final product, service, or system will already reflect people's desires or needs, and it's less likely to fail, and it's less likely to fail when you finally scale up. So that's really human-centered design. And in the last 10 years or so, I think design has sort of earned a table in projects within the development sector for this reason. So they bring us in to work at a smaller scale before they try something for a randomized control trial or at a larger in a larger geography. Coming to our project itself, like I said, we were exploring if AI can be used to improve hand washing, and the device that we had, we didn't develop it. It was our partner's product, but the product had two parts. As a first part, there was a screen put up above the basin where a user can see the WHO protocol. There are 6 steps, 6 core steps. And there is a camera attached to it. The camera can only look at the health worker's hands and detect whether they are following those movements. If they follow it correctly, they get a green tick. If they don't, they get a cross. And all that data which is collected at the basin is available on a dashboard in an aggregated and anonymized fashion to the management so that they can see how their ward is performing. So these are the components of the device we were working with. This is just an overview of the sites. These are different states in India, and there are 6 hospitals across sort of scale. So right from the sub-district level to the district level. And these are just some images to give you a sense of what our work on the ground can look like. So like I said, the story starts with research for us. So we visited all our project sites, spoke to more than 30 people. And I just emphasize here that it was also across staff hierarchies. And some of that work continued on WhatsApp as well, because a part of our project overlapped with COVID. And through all these conversations, we actually heard a lot, because we were not only interested in their relationship with technology, but to also understand how the core behavior, that is hand washing, is practiced on the ground. I'll read a few from here maybe because it might interest you. So, for example, somebody told us how they lost some of their colleagues to COVID, and out of that fear, people wash their hands more carefully now. Or somebody else was telling us how actually the wards don't even have the right hand hygiene supplies. Those supplies only come in on the days when you have someone walking in for an external assessment. So your facility actually has to look good. On every other day, either the staff is buying their own soap or they're making do with whatever they have. So these are just some stories. I won't elaborate on all of them. So now after having heard all of that, we had used a tool which is, more useful for those who are working in behavior change, which is by the Manoff Group, which helps you sort of identify factors, behavioral factors from all the information you've heard. So to simplify that, what I mean to say is we wanted to come up with 7 to 8 things which actually affect people's ability to wash hands in the first place. And of course, we had other questions related to technology, but I thought that these would be of interest today. So that's what I'm presenting. And the first one, and the most important one that we heard repeatedly, was lack of time. So a lot of staff members would tell us how they actually cannot practice hand washing because there's a severe staff shortage on the ground, because of which they don't have time to either learn the protocol, practice it so that they can memorize it, or follow it during service. This can get worse actually at the tertiary level, which is the apex of the healthcare system, because in those wards, they take care of more complicated cases. So this is almost counterintuitive, because one would imagine the bigger the facility, the more bandwidth to sort of work on quality improvement. But it can be the opposite, because they are completely inundated with how many cases they have. And most importantly, I mean, not most importantly for this conversation, if I was to link it back to the question of, inclusion, exclusion, or how these power dynamics play on the ground. Now, because they have a staff shortage, things can be quite disordered on the ground. So you get pulled in and out of tasks as they may require you to help. Which means that a paramedical worker might actually take up some clinical work as well, just to support the nurses. And the people who are most likely to be adversely affected by this are the non-medical workers, because they can be called on to help every other rank in the ward, but no one will take up their work. So, like I said, like cleaning work is considered dirty, so they still have their jobs to do, but then they also have to help everybody else. So this question of lack of time, because of which you can't take care of yourself and wash your hands, affects different people differently. Um, the next, I'll try and cover cohesion and inclusivity together. So what we then realized is that there are uh, again, this kind of staff hierarchy sort of plays out in training, communication, and supply allocation as well. So very often it's the medical workers who are more likely to be sent for training, which means that the para and non-medical workers might not even know the protocol. A lot of the communication material is not designed keeping their literacy levels in mind or their language preferences. They don't speak English, they don't know how to read English. And the last and most interesting is supply allocation, which means that when there is a shortage of gloves, which is very often, or when there is a shortage of sanitizers, which is very often, you will hear statements like, they anyway don't do any patient work, so you can give them the flimsier gloves. When actually people who take care of biomedical waste are equally susceptible to infection. So given these power dynamics, actually, we realize that your team or your work culture is extremely important. Cohesion is extremely important if you want to bring about behavior change, but also if you want to introduce digital solutions for that problem. Because if it's an amenable work culture, people will help each other. If it's not, you're more likely to throw each other under the bus when you have a shared goal and it's not getting fulfilled. This other one, which is of competing protocols, I will speak quickly about it, but I'm happy to take questions later. So, like I said, that our device actually followed WHO, which is a globally recognized guideline. But on the ground, people have local ways of washing their hand, like variations of that protocol. And there's definitely this tension between what we as program implementers decide should be enforced in a certain environment versus what they are used to following. I would imagine that the tension here is one of a more global scale. We can come back to it later if it's of interest to anyone. Um, and then what we very often heard is, I'm translating for you. It was usually told to us in Hindi, but we would often be told that you are asking us to follow the WHO protocol. Where is the evidence that this protocol is better than any other? And actually, there's no evidence as far as we've looked for it. So, they didn't have a satisfying answer to the question why. Um, Lack of awareness, like I already said, not everybody has equal access to training, so your understanding of the importance of hand hygiene may also vary. And the last really is that when you're working in such an intense environment, you typically need a carrot or a stick to prioritize any behavior. In this case, it was hand washing, and that is typically missing. People don't get recognized for their hard work, and or even the opposite is true, that if you don't follow it, there is no negative consequence for it. Can someone just help me with how much time I have left? Is it 5 minutes?
I would say a couple of minutes. That's okay.
Okay. Okay. So, based on everything we heard, we, like I said, we developed rough and ready solutions. We have something called concept cards, which is a rough sketch of what we'd like to suggest as solutions. Had multiple discussions with people on the ground, and came up with digital improvements, but also non-digital interventions. I'll quickly sort of explain how we were thinking about it. So the new screen for the device, the new interface for the device was actually based on GIFs and videos. So it didn't require too much literacy. You could see the hand movement and copy it. It also had a local mascot, something that they could resonate with. And as you can see, the writing was in a language that they recognize. Um, the dashboard that I showed earlier, actually, the managers found it very, very hard to use. So that was sort of crystallized into a performance report that you could get on your phone. And this is an interesting question on how you can use visualization to make data more accessible to people, because it was digested and presented in the form of charts and graphs. There were also other non-digital interventions where we used videos, playing cards, games to help people learn the protocol. Um, and coming to the last part of the end evaluation, the program itself was evaluated in various ways, including with the data generated by the AI device. Um, and we did see improvements. So when we introduced the interventions, at some of our top performing sites, the compliance went above the global average as well. Um, so you can use the process of human-centered design to get somebody to be enthusiastic about a solution, to sort of fit it into their environment through this intensive process. But we're at the stage of also thinking about sustainability, because uh, one, how do you maintain that improvement is a question. And I'll leave it as a provocation, because I feel that the same sort of context specific approach needs to be needs to be applied to product upkeep as well. You can't just leave the device and expect it to work perfectly. It needs to apply to data accuracy also, and also the sort of support you give these facilities after you've exited as a formal project. So I will end there. I hope I haven't gone over time, and I'm happy to speak about any of this later in the Q&A session. Thank you so much.
Thank you, Niyoshi. That was perfect and so interesting. I'm looking forward to the many questions that people will have about your presentation. Eve, it's your turn now, if that's okay. Yeah, perfect. We can see your slide, but you're muted.
Typical, trying to find the mute button. Yeah, thank you for that. And I'm glad I'm coming after Niyoshi, because really what we were trying to do when we created sort of the decentralized solutions for clinical trials was try and take it out from clinical setting more to the ground, to the home environment, where a lot of facilities are not always available. So I'm glad I'm following after you. So mine is not going to be too much of a drop from the clinical setting into the home. But just before I get into what I'm going to talk about, I thought I might just include a short summary of what clinical trials are, just in case anyone on the call today is not familiar with that cycle. I know our next speaker is, and she'll be talking more about market access. So hopefully I'll be able to hand over to her to explain that a bit more. But really, when the sponsors, who are the drug development companies or pharmaceutical companies, as many of you might know them as, they're constantly working in the lab, trying to come up with products or molecules that will help treat disease. So in terms of that laboratory testing stage, that's happening constantly. And even before they go out to test in the animals and they're doing that in the labs, I've had people sort of say, well, some of these drugs have come out rather quickly, but what people don't ever get to see is the years of lab work that happens. And so I was hoping to highlight that with this diagram, that before we even get to testing it in humans, it spends some years in the lab. Then we go into animal testing where we just check the safety and efficacy of a product before we are even able to apply for permission to register a new drug, a new investigational drug, as we call it. And once the sort of animal testing phase is satisfied, then we start going into humans, and we look for a group of humans who do not have the disease that we're testing, who are considered to be healthy, all give and take. And we start that with a small group, and we test the drug to see if there's any effect on them before we are able to open it up to patient groups. And so these phases, when you see phase 2 or phase 3 in a trial, it just means we are expanding the population we are testing that drug on. And by the time we are getting to submitting the data, we've expanded it significantly to a large population. And once those submissions are done, then that's when it's actually sent out into the market. And the next speaker will talk about that. And once it's in the market, that doesn't stop the testing and the checking. It continues. We continue collecting any adverse effects. We continue collecting any side effects that patients are complaining about, and that gets fed back to the regulators who license this product, so that we're not sending out a product that isn't safe. And really, at the end of that, hopefully it gets to the market and everybody can get prescribed. But the importance of this sort of cycle is to make sure that we are testing it in the population that will most likely use that drug. And we know from experience that that has not always been the case, that the drugs have always been tested largely in white Caucasian population who are college educated and above, and most likely middle class. And so there's been a drive to see how do we get the testing to move to a population who will most likely be prescribed the drug in the end, so that we are accounting for any of those side effects that happen. We are accounting for how the drug is absorbed in the body and how efficient it is, because you'll be surprised that some people are genetically more predisposed to absorb a drug faster than others. And so without having them in that testing period, we don't know if one capsule will be enough for them or they needed two. And so having diversity in trials is really helping us make sure that the treatment is targeting each ethnicity as much as possible. So moving on then to clinical trials and decentralization of them. So the FDA very recently defined what this is, because a lot of people were using the word DCT and it was getting confusing. And so they helped us just summarize it nicely. So we're all sort of referring to the FDA definition, which says it really is a trial that is executed through mobile or local healthcare, as well as telemedicine. And you can also use processes and technologies which differ from the traditional trials, which usually happen in site. So as I was explaining in the previous one, and I didn't highlight that actually maybe only 1 in 10,000 products end up going onto the market. So a lot of work, a lot of money is spent in those clinical trials, only to end up being able to successfully submit one product for market approval. So during this testing phase, we discovered that patients drop out, and the average dropout rate is about 30% really on a trial, which might sound little when you think statistics, but if you think cost-wise, it's quite significant, because each patient that drops out, it costs the sponsor or the pharmaceutical company about $19,000 to replace them. And like I said, because these studies have been started in the labs, they've done the animal studies, a lot of money has already been spent by the time we're getting to the human trials. So really every patient we get is precious, and we want to keep them on the trial, especially if they're from a diverse population. We don't want them to risk losing them when we've been fighting hard to get them on a trial. So decentralization came in to say, how can we help you participate in a trial? How can we help you feel part of this? And I know Niyoshi was talking about the literacy levels and making sure the material is accessible, making sure that they even understand that there's a trial out there that they can participate in. And I'll come back to the barriers towards the end. So by including these things, we've seen actually that we're able to increase our recruitment. We're able to reach people a bit faster when we offer them the solution to be seen wherever they are. Maybe they're in their offices, in their schools, or at home, because committing to go back to a sort of clinical site setting every month or every 2 weeks in the beginning might not seem too bad, but then after 6 months or so of participating, that participant burden starts to kick in, life kicks in, and that's the time they most likely drop out. So really having this option of them being able to be seen wherever they are to continue participating in a drug trial has actually significantly helped improve that acceleration of the study. Apart from that, we've decreased the burden because 7 in 10 patients live over 2 hours away from their hospital setting, for example. And this is a number we've been able to verify recently. I know when I was working in a clinical setting as a study coordinator, I rarely asked my patients where they live because I just wanted them to understand the protocol and maybe enroll on the study. And where they live was rarely something I thought about. But this is something now, as we decentralize, that we're bringing to the front of people's mind. Did you know that they have to take 2 trains to get to you? Do you know that they have to find someone to drive them for 2 hours to get to wherever the site is? And all these factors were actually contributing to the dropout. Nothing to do with the drug not working, nothing to do with them not wanting to participate, but really just social and economic factors. The other thing is patient diversity, and I may generalize with this, but a lot of ethnic minorities have multiple jobs. So you're trying to work maybe 2, 3 jobs, and there's this study that you really want to participate in. It's in a disease area that you have, but you can't really afford to take time off any of those jobs because it impacts your financial status. So we found that actually just by virtue of that financial status, a lot of ethnic minorities were being left out of studies because they couldn't commit to coming back to a centralized site. So really offering them the option of we will come and see you in your home, or we will come and see you at a nearby clinic where you don't have to take time off work or during a lunch break opens up an opportunity for some of those ethnic minorities to participate so that we can start to test the drug in the population that will use it. And last but not least, it's sustainable. We all want to save our environment. So anywhere where we can minimize unnecessary travel is a plus. And we've actually started planting a tree for every patient we enroll, again, just to give back to the environment in that sense. So it's digital health. So I've talked about some of the patient aspects. So a bit of the digital solutions that we are using in clinical trials. Because we want to empower patients, especially if they have a disease that they largely manage in their home, say diabetes, hypertension, which affects a lot of ethnic minorities. They're already used to doing a lot of things themselves. They're already used to measuring their blood sugars or injecting themselves or measuring their blood pressures. So getting clinical trials that align with what their standard of care, what they would normally have makes it easier for them to participate and opens it up and makes it accessible. It's not another complicated thing that they have to understand. So if I start from the far right of the screen here, we've got the digital solutions, which is you want a patient to understand what the protocol is about. So we have e-consent, and what e-consent comes in is in a digital format. So they can make it bigger for those who have got reading issues. They can highlight the section that doesn't quite make sense to them so that when they come back to seeing the clinical team doing the study, they can ask those questions. I think you've all gone to a doctor's office and tried to remember all the things you wanted to ask them, and they only have 10 minutes to see you, and it's all out of your head. So making that in a digital format means they can actually interact with it before their appointment, highlight, even jot down the questions so that when they come in front of the doctors and the physicians, they actually know exactly what they need to ask to understand what that trial means for them and their disease area. In terms of telemedicine, this was again highlighted during COVID. We were able to see doctors through a screen on our phone. And so why shouldn't we continue with that, especially in areas where the ratio to a physician and patient is so high? So if you have like one physician for 100,000 patients, it's impossible for that physician to see them all. So really allowing them to see them maybe through the screen opens it up to more physicians being able to help, and actually more patients receiving that care that they need at that local level. In terms of wearables, I'm wearing a smartwatch. Most of us might be having one, and we're all measuring our blood pressures, measuring how we are waking up and sleeping, and it's telling us, oh, I think you slept 7 hours today, maybe you need to sleep a bit more, etc. So we're leveraging things like that for research as well, so that patients don't have to remember to log how many hours they slept. We can get that directly from their wearable device and log it centrally and submit it as part of the trial data. In terms of medication adherence, we were never sure whether patients are taking drugs at the same time every day, or whether they're taking it at all. So now we have digitalized sort of blister packs that can tell us the patient has actually popped it at this time, and we can start to match and see, did they take it at the right time? Is it not efficient because they've missed many doses? Or is it just not working even though they're taking it as they should? So there's a lot that's happening in the digital health space. And whilst this is for clinical trials, it's also quite transferable in the clinical healthcare setting, because you have patients who have memory problems, who may not remember whether they took a drug. And you can use some of these methods to try and just give them those prompts, help them maintain the consistency. Then moving on to the near patient solutions, and I will talk about the home trial services, which is what has been the driver for bringing trials in the home. We also have mobile sites. We can pack a van in a church, in a local supermarket. Not everyone wants to be visited in their home, but they'll quite happily walk 5 minutes down the road to a mobile van, have their drug, have their tests, and go back home. Again, that opens it up to some of the ethnic minorities, especially if it's factory work. We can go and park that van in a factory, wherever they are, and then they can pop in during their break, have their test, have their drug. Again, we're giving them opportunity to participate in the trial. And last but not least, we've got the community bucket, which is working with GP clinics or local physician clinics, pharmacies as well. And even some of the retail pharmacies are able to participate and allow patients to enroll on studies and receive their drug through there, especially if it's an oral drug with a minimal intervention. So all these are some of the ways we're looking at increasing diversity, opening it up to participation, and making it easier for the patients. So home visits. Some of you may have not seen a protocol, but what happens is we've got some visits like MRIs, scans, and all those need to be happening at a brick and mortar site or a physical location. But then there are other visits that don't need to keep going back. So we look at a protocol and we advise our clients on which visits can actually be done in the home or in another setting outside from the physical site location, and the ones that need to be grouped. Because what we want to do is make it easy for the patient to remain on the trial, kick in when that fatigue is there, and say, instead of you coming back for 10 visits, you can have 5 at home and just come back for 5. And we find that actually that really encourages patients to remain on a trial until the end, so that drugs can get to the market faster. I think people who ask me, why do we need to have all these visits done? It's because if we don't get the data in time, it delays the drug going to the market. And actually, the average time for a drug to get to the market is 10 to 15 years. So any time we can shrink on that means a life-changing treatment can become available sooner if our patients don't drop out and remain on the trial till the end. Having talked about what we do in terms of opening it up, we know there's challenges in terms of ethnic minorities being able to participate in trials altogether. So historically, there's been an unconscious bias about whether people from ethnic minorities will even want to participate. So they rarely get offered the opportunity sometimes. there's also that literacy level. So if all the materials we are pitching are at that sort of college and above, then anyone with that below that level will not even understand what those posters mean or what that trial means. And so because it's all alien, no one even gets involved, even though it's something that actually would benefit them. Historically, there's also been I would say, publicity on the trials that were run, unfortunately, in a bad way in the 70s and earlier, that targeted minorities. So a lot of them were tested on drugs without their knowledge. And so that sort of concept has continued even today. So people think that they're being used as guinea pigs. And so it's up to us to sort of work with them, increase awareness that actually now we've got good clinical practice guidelines, that no one can do anything on you without your consent and without your awareness, and that what happened in the 70s and earlier actually led to that regulation being made. So, but there's that sort of inherent understanding that we're going to be tested on without our knowledge, or they're going to sneak in some things that they haven't talked about. And I've had that from people from ethnic minorities who say, I don't want to be used as a guinea pig. But then what that does to us is that we then get left out of a clinical trial, and we get left out from them understanding how that drug would affect people like us. And so it's sort of a knock-on effect, which delays, again, access to therapies that are suitable for people from ethnic minorities. And lastly, I did talk about distance to site and just how far they have to travel, as well as family commitments. And all those things work together to make it really hard for the patients to participate. And to just bring this to a close, I wouldn't be speaking scientifically if I didn't have some of the data to back this up. So Health Match is an organization that works with ethnic minorities, and they asked over nearly 8,000 patients actually about what are some of the things that would help you participate in a trial, because we want them to participate. At the moment, the numbers are very little, maybe less than 10% in some cases. And we want to make sure that actually they can access all this information in the level they can. And we found that actually people have caring responsibilities. I'm not going to read everything on here. They want some compensation for their time. They want to, they apply for it and then they don't quite get through with it because they just feel like they don't meet the criteria. So they disqualify themselves even before they've gone ahead with it. Asian women were likely to say they have caring responsibilities. I've got like extended family, so I can't commit to all these things as well as my extended family. So again, that's someone who you would want to be offering a home visit so that it doesn't affect their sort of family dynamics. But they all felt that they want to participate, but they just find that it's a bit difficult because of these life and socioeconomic challenges. So based on that research, my encouragement to anyone sort of who is thinking of a clinical trial or is in that early stages is let's think about the patient and caregiver burden, because it's not just the patients. They all have or may have care partners who are there to take them to the hospital appointments, etc. What kind of burden are we putting on them when we ask them to participate on a trial? Also think about the social economic. So is this their only job? Can they actually afford that smartphone to be able to log those digital parameters? Do we need to provide them with a smartphone? Do we need to pay for broadband, for example, or the cellular to go with that smartphone so that they can participate in those digital tasks? And always engage with patient groups, patient advocacy groups, so that we can hear it from them. What would make sense, what would make it easier for them to participate, and what they'd like to see. So rather than us sit in an office thinking what they might want, let's get back to the patients and ask them. And really taking time to give them education so that where there's been misunderstanding, miscommunication, that is clarified. And really, that's the only way we're going to enhance representation from a place of understanding and informed consent. Thank you, and I look forward to seeing any questions that have come through as I spoke.
Thank you very much, Eve. That was fascinating, and I also look forward to hearing any questions that the audience will have. There were some issues with the chat function, but it should have been enabled for everyone now, so it should work. We will now take a break for like 7 minutes, I would say, up to the hour, so 3 o'clock in the UK. Okay, I think we can move on to the last speaker, Srushti, who was going to focus on perspective and processes involved in market access of digital health and associated ethical issues. So I'll hand over to you, Srushti.
Thank you so much, Arianna. And yeah, thank you so much, everyone who's joining in. I will quickly share my screen. And again, I would also like to thank the organizers, Matimba and Kumari, for this organization in general, and also about the seminar, and also giving me the opportunity to share more about my experience as a pharmaceutical consultant, and also talking about a little bit of ethical issues associated with it. And I think this really nicely ties into what Eve said and what Niyoshi said at the beginning of the seminar. So again, I am going to give you a bit of stakeholder perspective from the pharmaceutical industry side of things, because I work as a pharmaceutical consultant and we support big pharmaceutical companies get their drugs into the market. So now that you know all about the clinical trials and you know how patients are enrolled in a clinical trial, what kind of resources they need, and how once it's done, once the evidence is collected, and once that digital technology is approved, how it enters the market and is available to a much larger audience and wider audience. So again, it's me, Srushhti Trivedi. I am a pharmaceutical consultant with a bioethics training, and I'm going to talk about perspective and processes involved in market access of digital health, and what are some ethical issues or ethics processes currently established, and what are some ethical issues that are existing. So in my talk today, I'm going to again briefly start about understanding of the healthcare system, since I'm based in Canada currently. I was talking about the next slide, but yeah, so agenda for today's talk is first of all understanding a little bit about the healthcare system in Canada. So for those of you who are joining from the UK, it's very much similar to how you have, since it again follows a similar principle of universal healthcare. But for people who are joining in from the different parts of the world, again, this is a snapshot of what the system looks like in Canada. Then second would be the drug approval process and the funding process in Canada, and how these drugs are reimbursed. So as Eve mentioned, there are millions and millions of resources, not only in terms of finances, but human resources that are involved in getting a single drug or single medical technology, medical device in to get it approved. So how are, from an industry perspective, if a pharmaceutical company, majorly a biotechnology company, if they are investing in so much resources, they need to get it reimbursed. And in Canada, it's usually reimbursed from the government that we have. So I'm going to talk a little bit more about that. And then in the end, what exactly is market access? I'm going to also talk about stakeholders which are involved. So it's not only one stakeholder, which is the pharmaceutical company and the government, but again, as Eve mentioned, it's a lot of perspectives and stakeholders in terms of patients who are in the end receiving it, also clinicians who are prescribing it, and even the hospital who's making these drugs available. And in the end, again, there are ethics involved in these processes as well. And then what are some challenges that are currently existing and currently foresee with evolution in technology as we get more and more advanced with the technology. So next slide. So I'm going to talk a little bit more about the healthcare system we have in Canada. So Canada is a publicly funded healthcare system which is dynamic, and reforms have been made for over, I would say, 4 decades. And again, it continues to changes its response within the healthcare system, with changing in changing in terms of the disease that they fund or drugs they fund, and changes that are happening in general in the world of medicine and throughout the society. And however, it remains the same, that universal coverage that we have for medical, which is medically necessary for healthcare services, are provided on rather need basis rather than the ability to pay. So if you're a patient who goes to the hospital, and if you need it, and if you are paying taxes, you will be given all the services which are covered under the state health and also under the federal healthcare that we have. So again, the basic value of fairness and equity that are demonstrated by the willingness of Canadians to share resources are also reflected in this healthcare system, and there have been major reforms being constantly made. Again, the system has been made constantly modifiable, depending in terms of countries' needs and circumstances, and as the nature of healthcare in general. So as Canada has a lot of immigrants and a lot of ethnic minorities, and also has a lot of people of color involved, they're constantly changing in the ways they provide care to specifically those population and understand their needs. So again, it started with Yes, so it started. So basically, the healthcare system started at because of the Canada Health Act, which provides an equitable, fair access and healthcare services, healthcare resources to all its Canadians residents. And since this act resonates with the Ministry of Health, so basically this act is enforceable, and it's responsibility of Minister of Health to fund it. So again, these are funded by this agency called Health Canada. So Health Canada is an agency that's responsible in approving drugs and making it more accessible to all the healthcare system. So again, it's not just one agency, Health Canada, but multiple agencies that take care and have taken different roles. So as you can see, we have Public Health NOG, we have Canadian Institute of Health Research, Canadian Food Agency of Inspection, which is kind of like an FDA. And then we have Health Canada regarding all the healthcare resources and drugs as well. So now that we have understood a little bit more about the healthcare system in Canada, I want to talk more about the drug approval process and the funding process. So, but I'm going to talk a little bit from a Health Canada perspective, and then on the next slide, I'm going to talk more about the industry perspective, or the pharmaceutical companies perspective. So again, basically, it all starts by when the drug is approved by Canada. So before that, it needs to be approved by CADTH, which is again an independent agency that recommends a drug. And once a company has received its recommendation, then it reaches this PMPRB, which is Patented Medicine Prices Review Board. So Canada wants to make sure that it's priced at a cost-effective level, if it's fully funded or partially funded, and then it's finally approved by Health Canada. So again, in Canada, we have different agencies. We have CADTH, but we also have INES in Quebec, which is a province. They have their own separate health recommending institution or agency. And then we have private insurance, which are the employers who also provide access and coverage to certain drugs. And again, this is an established process currently. And that's why we talk more about drugs, but this process is constantly changing. CADTH has different processes for, I would say not different, but similar processes for medical device, and also for integration of these new digital health technologies in pharmaceutical side and also at the hospital side. So again, they are constantly reviewing and updating their guidelines, but this process has been approved since quite a lot of decades, and that's why it's currently, I would say, very concrete for drugs. So next slide. So yes, this is drug approval process from a manufacturer's perspective. So again, from the industry perspective, once, as you've mentioned, they conduct clinical trials, and it's proven effective in patients who are enrolled in clinical trial. And after years and years of different phases of clinical trial, then it submits their product up at Health Canada. So again, there's a product submission takes place, and as a regulator, it acquires all the regulatory approval, and then again it goes to CADIT, which is again an agency that usually recommends drugs in terms of funding and also in terms of the evidence that they have to show. So a lot of these clinical trials and a lot of these industries or pharmaceutical companies, so what they do and what is also related to what I do in my current role is they have a lot of clinical trials. So they want us to collect and give us a cohesive, comprehensive combination of all the evidence which is presented for that drug and for that particular therapeutic condition. And once they produce a concise document that provides all the information of all the clinical trial with all the data analysis process, they submit it to the CADIT. And then once it's approved by the CADIT, once it's recommended by the CADIT and approved by Health Canada, then it goes to the provincial level, which again approves it based on its funding. So again, this is the submission, product submission is often labeled as health technology assessment submission, which happens. So this is the process that is usually followed from a drug a manufacturer perspective and also an industry perspective. So again, there is a growing trend in Canada for utilization of the real world evidence data and how even when the drug has reached in the market, there's also a process of how it's doing and what kind of processes and responses a patient is providing with respect to that drug as well. So coming to the market access side of things. So again, market access is exactly what I talked about. That is the ability for a drug to achieve through a health insurance system, which is reimbursed for the price at a favorable prescription, and it's usually recommended. So again, in UK and Canada, in EU, there is one nationwide coverage which is provided to all its citizens, which is quite different from how it's reimbursed in US and in India, in China, which is a mixture of private and public payer system. So again, reimbursement is really important because in the end, if you go to a doctor's office and they prescribe you medicine, who are they in the end? Who's paying for that medicine? Say in Canada, you just walk out, but then in US, you will need to pay a fee. So who are you exactly paying? Are you paying the government? Are you paying the industry? Or who is paying for that drug for you? So again, there are these kinds of questions that are usually answered. So again, and this health technology assessment is used to aid that decision on the reimbursement of pharmaceuticals or recommendations of drugs, which is there. So again, it starts at a regulatory approval. So once a drug has received a regulatory approval, it goes to the national pricing and reimbursement process. And then again, it goes through current guidelines which are used to prescribe for that particular condition, and then it goes to clinicians who would actually prescribe this to an individual patients. So this is usually the process. And now talking more about the digital health aspect of it. So as Eve mentioned about different kinds of telemedicine and different kinds of medical not medical devices, but these devices like smartwatches, can they be considered a medical device? And the answer for that is no, because these are not medically approved devices. Even though they do collect medical data, it's not being currently used, or it's not being reimbursed by the government. It's usually being reimbursed by the patient itself, who has the ability and resources to buy these kinds of technologies. But since we are moving ahead in technology and it's constantly changing in the world of medical devices as well, we want to know that if a company is investing all their resources and money in developing these technologies, it will be reimbursed and it will reach a patient who is in need. So it will reach the market, because it's difficult. Most, I would say, as he mentioned again, 1 in 10 drugs and even these kinds of devices don't actually reach the market because they are unsure about the patient population who is actually going to use it, or there is an ambiguity of it being reimbursed in that particular country. So again, why is market access important for the society? Because it sets a fair price. You don't want, or you wouldn't want to pay overpriced for a drug, because healthcare is a basic necessity, and we need to make sure that there is a set price which is cost effective and affordable for everyone. Not only favors people who are able to afford it, but it's also if cost effective, and it provides an equitable access, and it creates an impact at the patient irrespective of the economic and social background. So again, the main objective of market access is to achieve an optimal price with the maximum reimbursement and maximum reach to the patients. So this again talks more about the stakeholders involved. So as I'm not sure if you can see my screen, but there are different stakeholders who are involved at different processes. So again, it starts with the industry, where the ideation and preclinical lab work processes that happen. And in the end, it's also involved high involvement at the data gathering. So once an industry has an idea, it evaluates it using preclinical stage, clinical stage, and then it reviews it with multiple stakeholders internally and externally. So it does a lot of talks with clinicians, industry, market access, the price point, and then once the decision is made, they gather the data, and then they actually put it through the market. There are also public and private hospitals who are also involved, where these clinical trials take place, and which is constantly feeding into the data, which helps in the market approval of this drug or that medical device. And then again, there are these committees, special government agencies or committees, which review these kinds of products, review the evidence that they have generated, and review their legitimacy, that okay, this drug is actually showing health outcomes and health efficacy in this patient. And again, in the end, there are regulators, and there are also national health programs which actually fund these kind of drugs and these kinds of medical devices. And again, and another important thing with these kinds of agencies, the data you provide needs to be equitable. And now post COVID, as you know, that people from ethnic minorities were affected the most. There was not enough data to support that this COVID vaccine is needed most by that particular group. So that's why now that they review evidence, they also see that, okay, it is actually clinical trials are conducted in the patients who need it, and it is in a setting which is usually will be useful for the patient as well. So now let's talk a little bit more about the ethics of it. So again, there is ethics is currently being involved at these processes. There are ethics groups and ethics experts at these federal agencies, and even in these kinds of pharmaceutical companies who support in making it more accessible and more equitable. So again, internationally, the ethical consideration have been incorporated in this health technology assessment work, which is done by these different agencies. So again, I have a few names. So just like we have in Canada as CADIT, in UK it's NICE, in Sweden it's National Center for Priority Setting in Healthcare. We have IQVIG in Germany, HAS in France, and then also in Netherlands. So again, these usually help the decision makers who are recommending these drugs provide a rationale. So these committees make sure that yes, it is the clinical trial and the data is equitable and has been conducted ethically. So it also prepares the decision maker to be ready for if there's any controversy or public response that takes place. So, as you know, that there are certain products which were approved, and then later on, they found out that there was any carcinogenic products involved, or it has an effect causing cancer. So again, if there is a public response, or if there's a test which shows how to respond. So again, it also helps in balancing out things at a systems level, at an individual level. So again, at a system level, it makes sure that it reaches the maximum population, maximum patient, but at an individual level, it also means that they are cost effective and everyone is able to afford it. these committees or these agencies also have a scoring system, which is called multi-criteria decision analysis scoring process, which is usually used, and they help in preparing the recommendation of a particular drug or particular technology. And again, ethics process has also identified concerns regarding emerging technology, especially in the brain computer interface kind of technologies that we are developing, and also certain diagnostic which are used, since they only favor since the data fed into these technologies is only from a particular background, or only from patients who are suffering from a particular condition, it can also give biased results. So moving on to, again, some challenges which are currently existing and foreseeable with this kind of technology. So again, there is a scarcity of well-designed trials and inconsistent real-world evidence study, which are still there. It's not so evident in clinical trials of drugs, but it's still there when it comes to medical devices, digital health technologies, and again, different diagnostic processes and services as well. And this also ties in, my second point ties in very well with what Niyoshi said about this device user interaction, that if you're designing a device for patients, we need to make sure that people who are enrolled in the trial are able to understand it. It's in a language which is not complicated, and it does not have any jargons, and it's, again, user friendly. Another challenge is the short product life cycle. Currently, if an industry is developing medical device or technology, since it's skipping all the preclinical work, it directly reaches patients. And if it's not effective in patient, it doesn't reach at a market approval stage. So again, shorter product life cycles is something that's also challenging, because again, with evolving technologies that we have, if it's pulled away from the market or it doesn't reach the market, who's going to pay for it? And then lack of directed medical outcomes, because these technologies currently are niche but not specific. So again, we need more evidence, more literature that supports specific medical outcomes that these kinds of medical device technology will be using. And again, my last 2 points are something that which is foreseeable, that we need specific framework and guideline to have an established process like we have for drugs, that there is still an opacity and complexity in reimbursement process for medical technologies and digital health. And that's why it's very difficult even for these companies who are developing these products and also getting it approved, since there is no clear process. You are doing a lot of trial and error, and again, it's waste of a lot of resources in human side and also financially. So yes, this brings me to an end of my talk. So thank you so much everyone for listening. I think we will have questions in the chat. So I'm going to stop my screen share, and yeah.
Yeah, thank you very much, Srushti, and thank you to all the speakers. It was amazing. It felt like you were continuing the same presentation, you're adding to the same presentation. And I think this speaks to the great work that the organizers have done to put together this webinar. So thank you to the organizers as well. We do have a few questions. So maybe I will take advantage of my position as chair to ask a question that I'm interested, like I'm very curious to hear your answers to. And this is a question to all panelists. What inspired you to work in digital health or in the specific field you're working in, particularly with a focus on inclusionary health technologies? Eve, I see that you have unmuted yourself, so go ahead.
I didn't realize I'm volunteering myself. But I would say first and foremost, curiosity. I was quite curious to see what, coming from a nursing background, just wanting to know what technologies are out there to make it easier to do the work I was doing at the time. And then I kind of stumbled into clinical trials and realized that actually there's so many more things that we can use digital health for. Like I was talking about that medication adherence, just being able to find out, has a patient taken their medicine at the right time? That would have been us asking a question and relying on trust. And trust is good, but a wise person once told me, trust is good, but control is better. So, especially in the clinical trial setting. So for me, it's been that being able to actually quantify experiences in a more objective way.
Thank you. And Niyoshi, what about you?
So I was also going to say that I've landed here by curiosity, but I can just distinguish my answer slightly by saying that my curiosity is more of the kind where I stumble into things. So I didn't necessarily have a question in mind or something that I was seeking. But I often land up saying yes to things and then realizing what I said yes to. And I'm saying it in a good way. I don't say it with any kind of regret as such. Regarding the specificity of inclusionary digital health, I would just like to add that I have a feeling I would land up asking these kind of questions for whatever project I find myself in, because the question of I would say working towards a better world actually comes from the worldview I acquired in my early years, even before any professional sort of qualifications got added on. And I think that got cemented by an education in the humanities is all I can say. So it's more of a lens that I think I can't rid myself of even if I tried to. So and I just want to link that to the previous webinar that the Black and Brown and Bioethics had conducted, where
Sure.
I think Professor Caesar was talking about how bioethics actually comes from values and worldviews and culture, doesn't always necessarily come from a professional sort of training or medicine only. So just to draw
Yep.
that parallel.
Yeah. Thank you so much. And I have a follow-up question on that. But first, let's hear from Srushti.
Yeah, so I think I have ended up where I ended up. Two reasons, because of, I would say, one is combination of my educational background. So I think what initially I studied biotechnology, of how the medicine works and how these kinds of technologies helping medicine to bring better health outcomes. And then I moved on to study ethics, and I would say this is a combination where I could apply both. So this is an applied ethics which I'm really passionate about. So how I ended up in the health of digital space is also similar to why I started biotechnology, because I was curious in terms of knowing how innovation and technology are going to help at patient level and also at an industry level, because I know we cannot escape technology. It's not that it's not approved, it is integrated in our lives, and it's slowly becoming very important part of our life. So if we are going to use it in healthcare especially, we need to make sure that it's equitable, it's ethical, and yeah, we use it for all the right reasons that we have. So I think that's something that really interested me into this field, and particularly focus on the inclusionary digital health. So since I'm still quite early in my career, I think this got triggered during COVID times, when people from ethnic minorities, especially from racialized background, are affected the most. So while working at a public health agency here in Canada, we decided what's the most ethical and equitable way to give them the resource first, because they need more than everyone else who has the privilege of being inside their home. So I would say that's something that really inspired me to work more on inclusion, especially for people who actually need it. So yeah.
Yeah. Very interesting. And I think we have heard a lot about the opportunities that digital health provides through your presentations. Through the questions that we've received, I'd like to focus a bit more on the challenges now. So maybe we can start from Srushti. Of the challenges that you shared at the end of your presentation, which ones would you prioritize in terms of addressing for feasibility's sake on a practical level?
So I think first of all comes the cost effectiveness, that who's paying for it and how are they being reimbursed. So even though we are from a quite developed country of like US, Canada, there are still a lot of countries, low and middle income countries, where these technologies are hard to access because it's so ineffective in terms of cost. So I would say the first priority is cost effectiveness as a challenge. Even though we are developing, it's still not reached that is access to everyone, like polio medicine or a lot of medicine which is now universally available for everyone from low and middle income countries to even developed countries. And I would say second is concrete evidence in terms of framework and guidelines. Like I still see in my current workplace that we have clients who are all as confused as us, that they don't know how to submit to these kinds of agencies because there's no clear guideline or evidence, even though we are improving and working towards it. Something in terms of a concrete guideline and framework is really helpful, and that will just help patient to get these kinds of technology at a faster pace and much quicker than just wasting so much time, which is in terms of wasted in terms of logistics, about the trial and error part which is there.
Yeah. Sorry, I think there is a bit of a lag. So if I am jumping in a bit late, that's the reason. I wanted to ask a similar question to Niyoshi. So I guess I think you give a wonderful presentation on human-centered design for health technologies. But I was wondering if you had any comments or insights into what is the biggest barrier in implementing human-centered design in health in particular, or if you can reflect also on other projects that you've been involved in.
I'll try and answer that, Arianna, only because I'm still learning to own this design part of my work.
Yep.
But from what I observe, I think that different countries have different design culture. That's first. So in India, and this is all my opinion and my observation, but in India, it's very often first of all sort of appreciated for its aesthetic value. So you would go to a designer if you want a good looking logo or if you want a good looking website. The second thing that I have observed is that it's become more popular 100%, but also has it sits at this intersection between business and engineering, like these kind of professionals who figured profitable solutions, something there. So moving it from that identity and self-identity to working in the social sector, I think there's something out there which becomes a barrier. So how people perceive design and how design perceives itself. And the last thing that I would add there is that even as it makes this transition, or it has made this transition also to a degree, studios like ours have been doing this for a while. I think the training that designers are given, so there's a whole different set of challenges when you walk into hospitals, which I have started sort of calling sites of human tragedy, because you walk into death and illness and sickness. But there is no ethics training provided to designers from that perspective, because working in the social sector just becomes a choice. Like you're actually trained to make products and services. So there's also this gap of what education we're providing with what future in mind for design. I hope that at least begins to answer your question. But
absolutely, absolutely. So I think you were talking about like almost like a cultural disconnect or a a misunderstanding of what design could bring to the development of health technologies. And then you were also talking about like lack of ethics training for designer, which is very interesting because I've never thought about it. I think we are more used in ethics. We are more used to, if you're from a bioethics background, you're more used to think about ethics curricula for healthcare professionals, or even nursing students or medical students, but not for designers. So that was very interesting to hear. And I guess I'm going to ask a similar question to Eve, because as you were going through your presentation, I think you really made the case for decentralized clinical trials. And I was thinking, why is not everyone doing this? And so, yeah, my question to you is there any particular barrier that you think, in your experience, you've seen for why decentralized clinical trials may not be so widely implemented?
I'll probably start by saying they are widely implemented in North America, Western Europe, and some aspects of Eastern Europe. Part of my drive for diversity is to get more into Asia Pac, into Middle East, Northern Africa, and also the rest of Africa. So there's a push to sort of diversify the patients. So in terms of North America, this has been happening for nearly 20 years now. They've been seeing patients in the home setting. And when you come to Europe, already standard of care, they do see them at home. So I think it starts from naturally as a normal pathway for your disease. Does it get seen at home in your country healthcare structure? Do home visits occur as a pathway that you can be offered? And if the answer is yes, then we are closer to getting it to a clinical trial happening in the home. The second part is there's ambiguity in the regulations. So I think in the Western culture, if it's not really spelled out black and white, we assume it's kind of allowed. But in the non-Western cultures, if it's not written down, then it's assumed that it's not allowed. And so we find ourselves in that sort of lull where if a government has not defined whether this is permissible, then the culture in the non-Western countries is not to do it because the government hasn't said it or there isn't guidance for it. So I think a lot of the delay is just getting governments and healthcare organizations at local level to boldly say this is allowed, this is permissible.
Yeah. Thank you. And I guess another question for you is the following. Something that you've talked about in your presentation was how very often like a big barrier to participate in clinical trials is maybe like a logistical barrier, like distance to the hospital or time available to individual participants and so on. But I think, and you've mentioned this as well, that sometimes the main barrier is trust, and that is particularly the case for some population groups, who often those who have been exploited in the past, including in health research. This group may distrust the medical system, right? And so perhaps they don't want their medical records or medical data being collected for research. And so one question for you is how you think that the decentralized clinical trial philosophy could help in addressing these trust-related issues in participating in research. And do you have any success story to share with us?
If I start by saying, first of all, it's representation, not just in the patients participating in the research, but also in the research staff. Because I think if I go into a place and I see someone who looks like me sort of explaining this process, I think my trust barrier sort of comes down a little bit more, and I'm more open to what they might say, because I feel like if they're convinced enough to be offering this to me from my background, then it must be okay. And I think that's been the gap, where things have been offered by people who perhaps don't understand some of the cultural implications, some of the challenges. And so if you first of all get research staff who understand that cultural barrier, you have a step forward. And then in terms of success stories, so we had a sort of an Alzheimer's disease study, and with Alzheimer's patients, they struggle to just leave the house, and just trying to get them out is a real problem. And they were in a trial, and they also happened to be a minority patient. So we were able to get a minority nurse to go out to them. And just because of that, they were able to trust them to do the tasks on them. Whereas they were having sort of, in their confusion, they were neglecting care from people who were of a white background. So being able to get a staff who looks like them instantly sort of calmed them down. I'm not saying that that's the only way, but that's just an example of how just representation can further help pacify an agitated patient.
Thank you. Thank you very much. We have a question for Niyoshi. On a practical level, where do you think responsibility lie when it comes to working on cohesion and inclusivity on the ground level? And again, feel free to draw examples from your own experience and your own project.
Right. Yeah. Thank you so much for that question, because it got me thinking. I didn't have a ready answer. So first of all, I've made two parts of it. One is to say that within the ward in the hospital, fortunately or unfortunately, in hierarchical work cultures, things flow faster when they flow from the top. So I can't necessarily say that the responsibility lies with the management, but what I can say is that the buy-in is better when they support it, or when they consider it a value that they should uphold. So we have also met managers who, when you walk into the hospital, you can see that they're doing well. And typically, if you, this is not an interview, but if you strike a conversation with them, sometimes they'll share stories of how they managed to do it. There was a lady who got talking with me and explained to me that the reason she is able to get the support she gets from her team is because she actually starts from the margin to the mainstream in some ways, like listens to the non-medical workers first and then works her way in. So we've heard stories like that. I think within the project, again, there I would definitely say it's a shared responsibility. If you walk into an environment where you can see what we would commonly just call toxic work culture, I think it would be very irresponsible to turn away from it and say that this is not our project. I suppose it's everybody's problem to sort of weave it into every choice you're of course going to it's of course going to be imperfect and you might not succeed, but like I'm saying, I don't think you can look away from it. At least I hope that that's not what we do. So I've just broken it up into two parts like that. And in terms of practical examples, I think that's what I tried to show when I showed like the user interface or the choices we made at that level, language, visualization, and so on. Do they bring about structural changes? No. Do they move the needle? I'm not sure. But yet you cannot not consider it. Like you can't make choices oblivious of what you've seen, is what I'm trying to say.
Yeah. Thank you. And I have a follow-up question for you. I think one of the perhaps downside of technologies like the one that you have showed, like the case study that you've talked about, is that they could be used for monitoring and surveillance. And I think there are increasing reports of how technology is being used in, or could be used in workplaces to monitor, workers' productivity when they take breaks and so on. And I was wondering whether that was a concern from any of the participants you engaged with, concerned that their practices, like hand washing practices, would be monitored, and if that could have any repercussion on their work. And if it was a concern, how was that addressed or discussed?
So I think I'll have to answer this in steps. First of all, unfortunately, these environments in which new technologies are being introduced, people have varying data and digital literacy. So the language in which some of this will be communicated with you will never sound like surveillance versus monitoring and evaluation. It can sound very anecdotal, and some of that interpretation and inference has to happen afterwards. So what we heard was a certain fear of the camera, and initially, and this is where research gets tricky. So they wanted to set up the device and collect baseline data, and so that the baseline data doesn't get contaminated, they didn't say what the device was for, and that scared people because they didn't know why that camera has been put up, and they began avoiding the basin. And if you ask them, what are you scared of, it was usually a sort of a nameless entity, like somebody is watching us. Now, is this the government? Is this your manager? That wasn't clear. Or is it the company that's put up the device? That wasn't clear. Um, the way that we tackled this or dispelled this was, so this project has had two phases at this point. In the first phase, the minute we got to know that this is a concern, we insisted on an orientation or an onboarding to start putting out a more correct narrative. The second, I mean, when we sort of expanded to other facilities in the second phase, we were very clear that we are, even if we're collecting baseline data, we will sort of put a caveat saying that yes, it could be contaminated, but we want to tell people what the machine is when it's installed. Like, let's not cause confusion. Is this completely effective? No, because those rumors come up every once in a while. And sometimes they're actually fueled from within, in the sense that, your seniors or the authority figures might, to get you to take it seriously, might say that, yeah, they're looking at your data. Now, who is they? Who's looking at your data? What are they looking at? We actually cannot see anybody's faces. It's never clarified, but it can sort of be resurrected every once in a while as like a boogie person. So that persists, but I can definitely say from the first to second phase, the confusion has reduced significantly, the fear has reduced significantly, just in the way that it has been put out. Yeah.
Yeah, very interesting. And I think it shows like the importance, like these examples show the importance of participatory methods and listening to your participants, understanding what their concerns and needs are. So thank you for providing those examples. And for Srushti, in your presentation, when you were talking about the ethics of market access, you mentioned that there are some additional concerns or maybe new concerns in relation to emerging technologies. Yeah, it would be great if you could expand on that.
Yeah, so I would say again, first of all, I want to continue on what Niyoshi was saying about gathering data collection. So, even when these kinds of big companies, big pharmaceutical companies, big biotech companies are developing these kinds of technology, they don't have enough evidence on if it is actually going to be effective or not. So they conduct a lot of focus groups, they conduct a lot of data before it reaches patients. So a clinical perspective, also a patient group perspective, also from at if you're going to look at the pricing model, that who are going to pay for it, or is it going to be reimbursed by the government itself? So I would say one of the concern is about reimbursement, because often when these technologies are developed, like facial recognition technologies that are now quite common, especially in the Toronto region of Canada, where is the money coming from and who's paying for it in the end? Is it coming from the hospital budget? Is it, if it's helping in the reducing the administrative workload, who's funding for it? Because in the end, if an industry is investing so much, where are they getting from? So I would say the number one concern with these technologies is who's paying for it in the end. Even when they are initial investments from a company, is the money coming out of patient pocket? If it's coming out of patient pocket, is it approved? Is it legally approved? So these kinds of channels are still missing. And another, I would say, with emerging technologies is with the emerging legislation. So in Canada, we have ADA, which is Artificial Intelligence and Data Protection Act. In EU, we have EU AI Act, which has surfaced and emerged, I would say, in last 2-3 years. How is that applied to these technologies? So again, there's still not enough clarity. And again, in terms of data collection, if there is data being collected, or if it is collected from a resource, which is the public health agency, do they have an ethics process in place? Like, or because I know in the industry, not all companies have an ethics board internally. So if it's a startup company or a small company which is gathering data from Canadian Institute of Health Information or Statistics Canada, is it being approved, or is there an ethics process in place of how that data is going to use in developing these technologies? So I would say there's still a lot of ambiguity in these kinds of processes. So I would say that just creates a lot of confusion, not only from an industry perspective, but also from the public health perspective, that even when they are going to establish this process, is it approved? Is it ethical? Is it legitimate? So I would say there are, again, these kinds of issues which are emerging, because we cannot stop integration of technology in healthcare. So the faster we work at creating different channels, approval channels, it will help in like better results and better outcome.
Yeah, thank you. I think we might have time for a last question. Very quickly, we'll do I think we'll go around, starting from Eve. And I wanted to finish on a broader question that may be interesting for those in our audience who maybe they're early in their career and they're interested in bioethics and they're thinking about career path prospects and are curious about what various roles people could play within industry to address health inequities through digital health, through inclusionary digital health. So if each of you could speak to examples of professional roles that you have seen in your own experience, your own companies, or through people in your network, maybe 1 or 2 examples that could inspire people in our audience who are thinking about career path, that would be great. Yeah, and let's start from Eve.
You make it sound like it's a simple question.
It's not.
It's a trick ethics question here. But, I would say have an open mind in terms of where your skills are transferable. So, for example, if you work in the clinical trials space, you could work within the monitoring bit, where you go out to assess how the trials are being conducted and whether the ethical standards are being met. You could also work in the pharmacovigilance team, where they're monitoring the safety of the product and the results that are coming back and actually deciding whether it's effective or not. You could work within the data management team, where they collect the data, they analyze it, and they look to see, has there been any scientific misconduct? Is there any data that looks like it might be forged? Are there so many parameters that are so similar that you want to deep dive into it? So that's all data management. And then, of course, you could work in the sort of safety assessment of the protocols when they come in, just to see, is this even ethical to be doing such a trial on this population? Should we even be doing it in humans? And the list is endless. I would say keep a very open mind.
Thank you. I think people will appreciate that answer. And Niyoshi, same question to you.
So from the ethics perspective, like I mentioned in my first answer, there are other disciplines which actually don't have a formal approach to ethics yet, an ethics review. So, in terms of career and inspiration, I would actually say that be comfortable with going by your intuition, asking questions that maybe others are not asking in the room, because that can lead you, and also be comfortable in occupying liminal spaces. I don't mean to sound abstract or conceptual, but I occupy a liminal space right now where I've actually studied writing and then I've gone to design, and I sit in many rooms where I'm sort of surrounded by scientists these days. But what that helps me do is pick the best of, if I'm supposed to word it this way, but pick the best of your world and see how it's applying to mine. And so it's okay to occupy that what is a highly uncomfortable space sometimes. Within design itself, I know that at least in the Indian context, there are people thinking about this question that if design through the development sector is being applied to these very delicate questions in health and education, how do we actually self-regulate ourselves? Maybe we don't want the same IRB process as it exists in medicine because it can stifle creativity. But then what is our response to this question of ethics? So this is when, being the right kind of outsider in all the circles helps, because you keep listening in and bringing in the best. But that's how I would frame.
Yeah. Thank you so much. And finally, Srushti.
I would say I would build on what Eve said. So again, keeping an open mind, but especially in the industry. So big companies like I know in Johnson & Johnson, they have a policy and bioethics team and director position. So if you want to directly influence the bioethics in the pharmaceutical industry, and if you have experience working in clinical trial or at a market access level, I think those skills are transferable directly in the industry as well. So there are positions at policy level and also at the bioethics communication level in pharmaceutical companies. But I also think there are positions, especially in these HTA body agencies that I mentioned. So at CADETH in Canada, we have ethics officers and people who are involved in developing these guidelines and frameworks. You can definitely leverage your perspective, especially in developing frameworks which are more inclusive, especially for people who are from a racialized background or ethnic background. So there are these positions, even I would say at the government level. There are public health agencies who need expertise of people who know these kinds of processes, and they can help you develop these kinds of bioethics or IRB process, and also help in developing educational, I would say, translation of research and science into it. Because as Niyoshi correctly mentioned, that we cannot use the same process in product design level. Like IRB, which is in medicine, cannot be directly applied. So being more creative. And also I would say another field of I would say in job perspective would be health data governance position. So since we deal with a lot of data at a clinical trial level and even at a market access level, how to manage that data effectively, and what are some current governances which are needed in terms of, again, legislation, frameworks, policies. So these are my three, I would say, ideal career paths that could be quite useful in combinations of, if you have, say, pharmacy and bioethics, or if you have a quite pharmacy background but you're also interested in ethics. So yeah, I would say permutation, combination of whatever your background is can be definitely be translated.
Great, thank you.
I wanted to tag on her and just say data management is not statistics, because people confuse us too. Please, just know there's so much you can do within the data management governance space.
Thank you. Thank you for leaving us with these inspiring thoughts about career path. And in general, I think that I hope that this webinar will leave like our audience full of ideas around the kind of digital health technologies that we would like to see in the world. And I'll pass it over to Kumari now and Matimba.
Yes, thank you, Arianna. And I do have a few announcements to get to, but before I do, I just wanted to very quickly thank all of you, so starting with Arianna for doing a brilliant job chairing, and then for Niyoshi, Eve, and Srushhti for all the wonderful things that you shared, your insights from experiences, which is very, very helpful to hear and sort of learn more about what's happening and what could happen. And to Matimba for putting all of this together, to the audience for joining, attending, and for all the questions. And now, very quickly, as I said, I have a few announcements about upcoming events that we have. So, wait, is it? There we go. Great. So very excitingly, we have our very first Black and Brown in Bioethics conference happening in 2024, engaging diversity in bioethics theory and practice. The conference itself will be on April 9th. And we just today opened up abstract submissions, so the call for abstract submissions. So send in your abstracts if you would like to be a part of it. It will close. So it started today and it will close on January 31st, so you have quite a bit of time. You are very very welcome to send in abstracts and attend the conference wherever in the world you are, because it will be hybrid, and also registration is free. And you can find more information about this online on our website, on the specific web page, for which I'm sure Matimba just shared the link. And then moving on to the next point. So yes, we have a Power and Privilege podcast coming soon. So there'll be a series of episodes covering different things within that theme or sphere. So we'll have things about publishing, academic hierarchies, and so on. So be on the lookout for that. Next point is to do with recruitment for research participants for a research project called Being Black and Brown in Bioethics, a qualitative study into the experiences of postgraduate researchers in different racial groups. So if you are a postgraduate student currently, that could be a master's student or a PhD student, or you are an ECR who used to be a postgrad at a UK institution, university or institution, please do get in touch if you're interested in being a part of this. We will also be sending out emails via networks and so on, asking people whether they're interested in joining. And so be on the lookout for that. If you'd like, you're very welcome to subscribe for our mailing list, and we will be sending out all information through that as well. So that's that. And then the last thing we just want to give a shout out for is that we won the Acme Paul Scotsman's Award for a research project of ours called Inclusive Bioethics, Modifying Methodology to Transform Research. So just wanted to share the wonderful news with everyone. But yes, so the announcements end there. And yes,
Thank you, Matimba and Kamau.
Thank you so much.
Thank you, everyone. Yeah, it was great meeting everyone.